Switching between tools for one project gets disjointed, especially on tight deadlines. Grammarly built a game-changing writing surface tailor-made for professionals to help you move your ideas forward and sharpen your writing. You can brainstorm ideas, summarize meeting notes in seconds, or strengthen a proposal without context switching. Easy to get started and even easier to finish. Sign up for Grammarly free and get your professional writing from draft to done. Visit Grammarly.com. That's Grammarly.com.
Steve Cubine and Nan McNamara's podcast, From Beneath the Hollywood Sign.
Wife pulls out a box and gives McAllister a ring, saying, "Here's something to remember me by." Daryl Zanuck hit the roof.
Mary Astor has been keeping a diary. This torrid affair with Georges Kaufman is chronicled on a daily basis.
Talking about the actors and actresses who won an Oscar on their very first film.
Get your fix of old Hollywood on the podcast, From Beneath the Hollywood Sign.
Well, hello there. I'm Nurse Mo, and this is the Straight A Nursing Podcast, where I teach concepts and share tips to help you thrive in school and at the bedside. So first off, if you are listening to this episode on the day it is released, Happy New Year. It is January 1st, 2026, and I have to say, New Year's Day is one of my favorite days of the year. You get to start over and everything is brand new and shiny, and I love it. And I also tend to clean out closets or do something like that. So whether you're cleaning out a closet, decluttering the kitchen, out for a walk, or you're listening to this at another time, maybe you're commuting, whatever, I'm so happy that you're here with me today. We are going to be talking about neuraxial analgesia. So what this is a type of regional anesthesia. So you may also hear neuraxial analgesia interchanged with neuraxial anesthesia, and I tend to go back and forth with it throughout this episode. So just know, talking about one and the same. So neuraxial analgesia is a type of regional anesthesia that utilizes local anesthetics or a combination of local anesthetics and opioids to produce sensory blockade. Spinal blocks and epidurals fall into this category. Some common uses are things like abdominal surgery, pelvic surgery. You'd be looking at like C-sections, for example, also used in orthopedic surgeries, as well as during labor and delivery. That would be your epidural. Now, higher level epidural administration can also be utilized for thoracic surgery as well. So you will see it in a wide variety of surgical and clinical applications. So first, let's talk about the differences between epidural and spinal anesthesia. So an epidural is when an anesthetic agent or combination of agents is injected into the epidural space. This can be done via a single injection, or it's pretty common for it to be instilled through a catheter where the anesthesiologist can then have a continuous, steady infusion of the medication for long-lasting pain management. Like, for example, somebody in labor, we don't know how long that's going to last, right? That could be a pretty long time. So they may have a catheter in place so that additional medication can be administered so that pain control is provided for a long duration of time. Now, a spinal block or spinal anesthesia is when the anesthetic agent is injected into the CSF, the cerebrospinal fluid of that intrathecal space, and it numbs the nerves that exit the spinal cord. Spinal anesthesia is typically administered as a single injection. You may hear this called a single shot in the clinical setting. So unlike an epidural, which could be a single shot, or with a catheter with the infusing for a longer duration of time, spinal's usually single shot. Other key differences between these two types of neuraxial analgesia include the onset, the duration, and the degree of pain control and motor block. So Looking at epidurals, again, the location is the epidural space of the spine. Location is going to depend on the desired dermatomal coverage area, and we'll talk more about dermatomes in just a moment. So it could be higher up on the spine or lower down on the spine. Onset with an epidural is 10 to 20 minutes, so it does have a little bit of a slower onset. And the duration, though, is one of its key benefits, is that the duration is adjustable when we have the indwelling catheter and can continue to provide anesthetic medication. For pain coverage, it may not provide full and total pain coverage, though it is pretty darn good. And with motor blockade, the patient should still be able to move the affected area. This is why we use epidurals for labor and delivery. We want the patient to be able to still push through active labor, so we wouldn't want to block all motor movement. Spinal, on the other hand, again, the location, that intrathecal, also called the subarachnoid space of the lumbar spine. And its onset is faster. It's going to be 3 to 8 minutes, depending on which anesthetic is used, and the duration, about 1 to 4 hours, again, depending on which anesthetic is used. Coverage for a spinal, when it's working, it should 100% take away all pain, all sensation, and for motor blockade, they're not going to be able to move. It will also block motor. So really be thinking about safety when you have a patient with an epidural, and especially with a spinal, because if they're not able to move, they're not able to sense, they are at higher risk for falls and other types of injuries. So a moment ago, I mentioned dermatomes. So what is a dermatome? So this is a really important concept in neuraxial analgesia. A dermatome is an area of skin that sends sensory information to the brain through a specific spinal nerve. You can kind of picture the body divided into strips, each served by its own nerve root. And you've likely seen a dermatome chart before, where it has the picture of the person and all the lines drawn showing what the dermatomes are as they branch off the spine. So when we use neuraxial anesthesia, we're trying to block sensation at certain dermatome levels. And these are mainly the thoracic and lumbar levels, depending on that surgical location and what is going on with the surgery. To get the right effect, the anesthesiologist doesn't necessarily need to inject exactly at the dermatome level. What happens is the anesthetic is placed either epidurally or intrathecally, and then it's allowed to spread. It'll spread up a bit, it'll spread down a bit, and reach that dermatome level that we want to be covered for the particular surgery that the patient is having. So for example, with a C-section, this requires a sensory block up to T4, so thoracic 4, and that's around the nipple line. For a knee procedure, the goal is to block sensation from the dermatomes that supply the knee and lower leg, which is generally L2 to L4, so lumbar 2 to lumbar 4. And this correlates with the front of the thigh and that knee region. So we're going to talk more about dermatomes when we talk about assessment as well, but that's a bit of a little overview of what they are. Another key thing to understand with neuraxial analgesia is the order of blockade. So it's not going to block all nerve fibers all at the same time. Different types of nerve fibers are going to basically absorb that medication or get affected by that medication differently because of their diameter differences, their myelination differences. And this is why patients will lose certain sensations, abilities at varying times. So we have the first that is blocked is sympathetic fibers, and this leads to things like vasodilation, hypotension, maybe some bradycardia. The legs may feel warm during this time because of that vasodilation. Next is pain and temperature. This leads to that loss of cold sensation, and this is going to come into play when we talk about ice testing in a little bit, and we use ice testing to determine if a block is effective at the dermatome level we want it to be. And if the patient can feel ice, then they are also feeling pain. So it's kind of a great way to determine if the patient's pain is being adequately controlled by the spinal or the epidural. So first is sympathetic fibers, then pain and temperature, then touch and pressure are next, and then motor fibers are last. So motor function, the last thing that's going to be affected. So with epidural anesthesia, again, they probably can move some. I wouldn't want them to be up walking around. That could be pretty dangerous. But with spinal anesthesia, they are not going to have any motor function. So keeping that in mind, again, very key patient safety situation. And then as the block resolves, it's going to resolve in reverse order. So motor function will come back first, then touch and pressure, then pain and temperature, then the sympathetic fibers. So when I'm taking care of patients in the PACU, when I worked as a bedside nurse there, first thing that my patient would notice is that they could wiggle their toes, and they'd get really excited because not being able to move your legs is an unsettling experience for people undergoing spinal anesthesia. So those wiggling of the toes, and then once that happened, I knew it was going to probably start resolving pretty quickly. It usually did at that point, and that I was going to have to start getting really on top of pain management because I knew that was coming soon. That pain sensation would be coming soon. So let's talk a little bit about the medications used in neuraxial analgesia. We're going to be using local anesthetics. You're going to see opioids used in some cases and epinephrine in some cases. So let's talk a little bit about each of these. So local anesthetics, commonly used ones include lidocaine, ropivacaine, and bupivacaine, though there are others. And how you know it's a local anesthetic is it ends in caine, C-A-I-N-E. Now, these medications block the transmission of pain impulses, and that is what produces that analgesia. In other words, those pain signals are not going anywhere. They're not going up to the brain to say, hey, my knee hurts because I got a whole new knee. We're not even sending those messages, and the patient is comfortable. Now, notice these are called local anesthetics, and they are administered locally, but they can have systemic effects. As we talked about, that blockage of the sympathetic nerve fibers, that has a systemic effect. We could have hypotension, we can have bradycardia, etc. And we'll talk a little bit more in a moment about some other things that can be going on that are not associated with the exact site where the medication was injected. The patient can also have something called local anesthetic systemic toxicity, or LAST. Now, I have done an entire episode on local anesthetic systemic toxicity, and that is episode 336. So if you want to dive into that a bit more, make sure you go and check that out. It's got a lot of great information that I would love for you to get your ears on. Another medication used in neuraxial analgesia is opioids. So opioids are commonly used and may be administered as solo therapy or in combination with a local anesthetic. Now, when opioids are utilized, things like respiratory depression and hypotension are going to be more significant, and in some cases, really, really significant. And then the other medication used is epinephrine. So epinephrine is utilized to prolong the duration of local anesthetics by causing vasoconstriction at the site. So it's given locally. And what this does is it slows the systemic absorption of that anesthetic. Now, do note that though it is administered locally, the patient can have some transient tachycardia when that epinephrine is used. And the recommended epinephrine concentration utilized for this case is the 1 to 10,000 concentration, which is the one that is utilized for IV administration. So we had local anesthetics, opioids, and epinephrine. Now, before we dive into side effects and complications, let's take a quick break. Now that the holidays have ended and it's dark at 5 p.m. and it's cold and rainy out, a little treat can go a long way toward brightening my mood. But I don't want to spend a fortune, which is where Quince comes in. With Quince, I can treat myself to everyday luxury items at affordable prices. And I have to say, I'm a wee bit obsessed with their Mongolian cashmere sweaters that start at just $50. Now, before you get skeptical, these sweaters look and feel luxurious. But because Quince partners directly with top manufacturers, they're able to pass the savings on to you. And even though Quince is known for their cashmere, they have other luxury items as well. Like, for example, something I'm really into right now are their Italian leather handbags. I've got my eye on the triple compartment tote in navy. It's so pretty, and I can't wait to treat myself to this as my new work bag. It will be the perfect pick-me-up for those dark winter days. Treat yourself this winter without the luxury price tag. Go to quince.com/nursemo for 365-day returns plus free shipping on your order. That's QUINCE.com/nursemo to get free shipping and 365-day returns. Quince.com/nursemo. So looking at side effects and complications of neuraxial analgesia, there are actually quite a few. So first we have some physiologic effects. These include things like hypothermia, hypotension, bradycardia, and the patient could even feel a bit sedated. Now, these effects occur due to the blocking of that sympathetic response, blocking of motory and sensory nerves, and the unopposed parasympathetic tone that occurs with local anesthetics and that sympathetic blockade. Treatment is aimed at addressing whatever the specific physiologic effect is. Note that hypotension occurs pretty commonly, can occur in up to 47% of cases, and is more likely to occur in patients who are fluid volume deficient and in patients who are receiving opioids via their intrathecal or epidural route. So hypotension is something you definitely want to watch out for, but also bradycardia can occur, hypothermia, and the patient feeling a bit sedated. Now, something called a post-dural puncture headache, or PDPH, can occur when the dura is punctured. And what this does is it causes a minor little CSF leak that causes a headache. This headache is exacerbated in the upright or sitting or standing positions. Associated symptoms could be things like nausea, vomiting, dizziness. The neck could feel stiff. They could have tinnitus. They could have hearing loss or vision changes, just all kinds of CNS type symptoms. Treatment for this includes hydration, so either oral or IV fluids, analgesics as needed, and simply avoiding an upright position, keeping the patient supine. Caffeine has been shown to also be helpful for some individuals, and then if it's just persisting and lasting for a really long time, like days or weeks, then an epidural blood patch may be needed to basically patch off that leak so that the patient hopefully no longer has their post-dural puncture headache. Another complication is urinary retention. Neuraxial analgesia blocks the afferent nerve signals to the bladder. And what this does is it makes the patient not able to feel if their bladder is full. They're not able to, the bladder's not able to do what it does to empty, so we get urinary retention. Now, this is more likely with spinal blocks, but it can occur with epidurals as well. The patient could also have nerve injury. While this isn't very common, they could have direct trauma to nerve tissue. Another one is a backache. This could be more of a side effect. It's more common with epidural anesthesia, and though typically mild, described as tenderness, it can last several days. I even saw one study that said it could even last weeks. So your patient could have a little bit of a backache or pain in their back. And then another very serious complication is a spinal hematoma. And this would be when blood is collecting in that space where that puncture was made at the spine. And if not treated pretty darn promptly, a spinal hematoma can put pressure on the spinal cord and cause irreversible damage and paralysis. So really important to be watching for any signs of spinal hematoma developing. It is especially high risk if the patient is anticoagulated, and is more common with epidurals versus spinal blocks. So it can occur with both. So I'm going to tell you a little story, and I probably have told this story before on this podcast, but with over 450 episodes, there's a chance you haven't heard it. So when I was working in the ICU, early on in my career, I came on shift to care for a patient who had had some kind of surgical procedure. I don't remember which type, but they had had a surgery. And with that, they also had a epidural. And they were in the ICU and getting antibiotics and all that good stuff that we give patients after surgery, especially those who have some kind of infection or high risk for infection. And unfortunately, back in the day, the Levaquin, I believe it was Levaquin, and the heparin were very close to each other inside our medication machine, our Pyxis machine. And what happened was that the nurse thought they were grabbing Levaquin, and this was before we scanned and did all of that with our meds, and grabbed heparin, hung the heparin, administered an entire bag of heparin. Just thinking about that is terrifying to me because incredibly horrible, bad things can happen when a patient is over anticoagulated. And in this case, we were very, very concerned about the formation of a spinal hematoma. So when I came on shift, I knew that those assessments were going to be critical for this patient. Now, the nice thing about heparin is that it wears off pretty quickly. So I kept a really close eye on her overnight. And then at that point, she was out of the woods and everything was fine. I will say that the nurse who made the med error did a great job owning up to it, because that's a terrifying thing to discover has happened. Owned up to it immediately, informed the charge nurse, immediately informed the physician, did all the things that they needed to do to basically take ownership of the situation and ensure that the patient got the follow-up observation and care that they needed. So this is just another great reminder to always do the 5 rights or 6 rights or 10 or however many you do in your practice, because mistakes can and do happen. So anyway, the short version is high risk for spinal hematoma in anticoagulated patients. Another complication is transient neurological syndrome, or TNS, and this syndrome involves pain and like a burning, tingling sensation in the lower extremities or the buttocks, and this occurs after the spinal anesthesia resolves. It typically does improve after a few days. Ambulation is really helpful, and NSAIDs can help as well. Now, this is more likely to occur with lidocaine and mepivacaine, which is a local anesthetic I didn't mention earlier. So more likely to occur with those two than with, say, ropivacaine or bupivacaine. And then local anesthetic systemic toxicity, I mentioned briefly, also called LAST. This can occur with any administration of local anesthetics. It's more likely to occur with epidural anesthesia than spinal anesthesia, simply because you give a higher dose. There's a higher dose of medication being utilized for epidurals than with spinals. And if you want to deep dive into LAST, go check out episode, 336? Go and check that out. Another complication is infection. Central nervous system infections can occur with neuraxial anesthesia and is going to be more prevalent. Of course, this makes sense among individuals who are higher risk for infection, immunocompromised, patients with cancer, patients with diabetes, patients taking long-term corticosteroids, etc. Now, meningitis specifically is more common with spinal anesthesia, while epidural infections are more likely to result in an epidural abscess. Falls, another huge complication we always want to be aware of with our patients, and this is because of that motor and sensory blockade. And also, I would say the hypotension, they're dizzy. Ideally, you're not getting anybody up who's had any kind of neuraxial analgesia, even though with an epidural, the The patient can still move their legs a bit. They're not safe to be getting up until that epidural is wearing off. And then with the spinal, they're definitely not getting up. They cannot move or feel their legs. And even initially, once this stuff is wearing off and the patient's exhibiting, good muscle strength and all of that, that first time they get up, you need to be right there, very, very closely monitoring them and making sure that you have a plan for if they start to fall, how, you're going to keep them safe, how you're going to keep yourself safe. So ambulation, 100% postponed until sensation and function have returned. And then there are some specific things to watch for with a high-level neuraxial block. And that's going to be anything in the cervical spine and anything that has migrated to a higher level of block than what was first initially expected. So you're watching for rapidly ascending, so going upward, sensory, motor, and sympathetic block. And what can happen when that block occurs higher up is respiratory issues, big time respiratory issues, significant respiratory depression. It can even cause paralysis of the respiratory muscles. Shortness of breath can occur. Hypotension, again, there it is again. Bradycardia, there it is again. The patient could have difficulty swallowing, difficulty speaking, and even loss of consciousness. So those are kind of your key complications. Again, that was physiologic effects like hypothermia, hypotension, bradycardia, post-dural puncture headache, urinary retention, a backache, nerve injury, spinal hematoma, transient neurological syndrome or TNS, local anesthetic systemic toxicity or LAST, infection, falls, and then that high level block, especially if it's unexpected. So that if it's unexpected, like let's say your patient got a C-section or is getting a C-section, you expect that block to be up at around nipple line. It could travel higher pretty easily, so you definitely want to be watching very, very closely for that. And if the patient is getting anything in the cervical spine, super high risk for those things that could happen. Again, looking at significant respiratory dysfunction for these patients, as well as hypotension, bradycardia, etc. Now let's talk a bit about nursing assessments for your patient who received or is receiving neuraxial analgesia. This is going to include hemodynamic status, respiratory status, sensory level, their pain level, and their motor function. So, and of course, you're also watching for any of those complications that I mentioned, urinary retention, spinal hematoma, LAST, all of that stuff. You're always keeping an eye out for that as well. So first, hemodynamics. Again, because neuraxial analgesia blocks sympathetic functions, vasodilation and bradycardia can occur. You really want to keep a very close eye on your patient's blood pressure and their heart rate. As for respiratory status, this really comes into play with those higher level blocks or blocks that rise higher than expected. Watch your patient for signs of respiratory compromise, such as dyspnea, any shortness of breath, low SpO2, hypoventilation, and difficulty speaking. If your patient is complaining of numbness and tingling in the hands, this could be a sign of a high block. If a high block was not intended, this is a stat phone call to the anesthesiologist. We're also assessing sensory level, and this is where those dermatomes come back into play. So to check sensory level, we use ice. It's a really quick and easy way to determine the level of the blockade. So to perform ice testing or cold testing, you can use an alcohol swab, but I just use ice because it is really, really cold. And first you want to take that ice and touch it somewhere that you don't expect to be affected, like touch it to their face or their hands or wherever. You basically want to get a baseline and make sure they're able to feel cold and communicate to you that they are feeling the cold. Then you take that ice and you head towards the area where you expect sensation to be absent. Ideally, this is going to be around the area of the incision. That would make the most sense, maybe a little bit above it. and move downward to determine which dermatomes are affected. And you're basically touching the ice, asking the patient if they can feel that. A lack of sensation to ice indicates the block is effective in that area or in that dermatome level. So for example, for a C-section, the block should reach T4, that nipple line. And for knee surgery, it should reach L2 to L4. You should also move upward to help identify if a higher than expected block is present. And where this ice testing also really comes into play is if your patient, let's say they had a spinal, they're coming out of their surgical procedure and they're complaining of pain, and you're not really expecting them to have pain right away because those blocks last a little bit and it should alleviate all pain. You can use the ice testing to determine if the patient is able to feel ice. That definitely means that they are able to feel pain. Now, speaking of pain, this is another key assessment. You're asking the patient to state their pain level. A higher pain score, again, could mean that the block is ineffective or just resolving really, really fast, faster than expected, or maybe there's some kind of complication such as a nerve injury. Maybe they have that TNS, which was the transient neurological syndrome. Maybe they have a hematoma developing. So we're always monitoring pain and assessing any complaints of pain. And we're also monitoring motor function. As the patient recovers from their procedure, motor function will gradually return. Remember, it's going to be more affected with those spinal blocks than with the epidurals, but you're assessing it, of course, on everybody before you're getting them out of bed. Ask the patient to wiggle their toes, and usually that's kind of the first thing that I'll see. Then you're asking them to move their feet by, flexing and dorsiflexion, plantar flexion there at the ankle. Then you're moving up to bending the knee and then lifting the buttocks off the bed. And when you're getting to that point, they're getting pretty strong. They're probably about ready to be getting out of bed. Again, with super, super close supervision and a plan in case things don't go according to what you expect to happen. So there you have it. That is your overview of neuraxial analgesia. Really hard to say. I struggled with that a lot. Despite that, I hope you found this super, super helpful, and I will see you here in a few days. And let me tell you what we've got coming up. We're doing something kind of cool this year for 2026. So on the Monday after a new episode, you can expect a short pod quiz on that episode's topic. So coming up here on this coming Monday will be a pod quiz on spinal blocks and epidurals. So I'm really excited about that. It's just another great way to test that you picked up what I was putting down so that you can take really good care of your patients or do really, really well on your nursing school exams. So I will see you back here in a few days. Again, we do brand new episodes every Monday, little mini episodes, and then every other Thursday, a bigger new episode. And then those alternating Thursdays, I pull something amazing from the archive of more than 450 episodes so that you don't miss any of the good stuff. See you soon. This podcast is brought to you by Straight A Nursing, a proud member of the Airwave Media Network. For more educational podcasts, check out airwavemedia.com. And for more nursing-related content, go to straightanursingstudent.com.